Good afternoon, everybody, and welcome. Thanks for joining us today's webinar. My name is Ken DiCercio, and I'm the Deputy Project Director with the National Quality Improvement Center for Collaborative Community Court Teams. You can see on this slide, if you're having any difficulty contacting us, we have the phone numbers you can call in, and we'll enter that in one of your questions as well. I come to you from Tallahassee, Florida, my home, and I'd like to acknowledge that I'm on the traditional territory of the Appalachian, Seminole, and Miccosukee tribes, who were forced out of their tribal land during the 19th century by the US government. I also want to acknowledge the contribution of the Seminole tribe is making to communities in Florida during this COVID-19 pandemic. They've been donating thousands of pounds of food to food pantries and community cooperatives throughout the state of Florida. In a few minutes, I would like to introduce our guest speakers and panelists, if you will. But before that, I would like to introduce Tracy Watkins, our Federal Project Officer for the National Quality Improvement Center for Collaborative Community Court Teams. Tracy is a child welfare program specialist with the Children's Bureau and has been really a leader in bringing the National Quality Improvement Center to fruition. With that, Tracy.
Good morning and good afternoon. Ken, can you hear me?
Yes, Tracy, thank you.
Okay, great. Good morning and good afternoon, everyone. I am Tracy Watkins with the Children's Bureau, and I serve as the Federal Project Officer for the Quality Improvement Center on Collaborative and Community Court Teams. It's my pleasure to welcome everyone to today's webinar. I'm so pleased to learn that over 1,400 participants have joined the call today to learn more about serving Native families affected by substance use disorder through active efforts and plans of safe care. As many of you know, Associate Commissioner Milner has laid out the vision and priorities of the Children's Bureau to serve families and children through primary prevention lens and minimize the disruption of families by preventing maltreatment and preventing unnecessary placement. And to focus our attentions, our interventions on the well-being of children and their parents and caregivers, and to build the capacity of communities to support children and families. I hope you'll find today's webinar and the information shared beneficial, enlightening, and helpful towards that end. And with that, welcome again, and I'll turn the webinar back over to you, Ken. Thank you.
Thank you, Tracy. We appreciate that very much. I just want to reiterate Tracy's welcoming as well. We have a little housekeeping item on the next slide, but I see many of you are entering in the chat box already, welcoming and hellos to each other. So thank you for that, and feel free to use the chat box. By now, most of you probably are experienced with virtual webinars one way or the other in one platform or another. So you can see how you can enter information, sharing with us and each other via the chat box. And then we'll use the question and answer box for you to enter any questions that you have of us, of any of the panelists, the presenters, any information that we can help you with. And we'll be monitoring that throughout the webinar. Due to the size of today's webinar and all of you who are out there, we're not going to be able to open the phones today, but we will give you our contact information so that you'll be able to contact us for additional discussion or information that we may be able to provide. We've got a lot of information to cover, and I want to get through some background information fairly quickly, so bear with us. I apologize for moving through some slides fairly quickly in order to provide enough time for our guest panelists and presenters, if you will. It's my pleasure to introduce today's presenters as well. First, Suzanne Garcia is a tribal legal and child welfare specialist at the Tribal Law and Policy Institute. She has worked for TLPI since 2015 on a broad range of projects, including those concerning child welfare, organizational change, and tribal, county, state, federal collaboration. Prior to working for TLPI, Suzanne was Assistant General Counsel for the Washoe Tribe of Nevada and California. She divides her time between living with her 90-year-old dad in California and her home in Northern Nevada. Welcome, Suzanne. Stephanie Weldon is our next presenter, and Stephanie is a Yurok Tribe member. and serves as the Yurok Tribe's Health and Human Services Director. The Yurok Tribe is the largest tribe in California. Ms. Weldon previously served as the Humboldt County Social Services Director and the Director of Child Welfare. She is currently working to develop Yurok Tribe's Title IV foster care program. Stephanie is the mother of 6 Yurok children and 1 grandson. She has worked to serve her tribal community for over 25 years in education and social service programs. Stephanie obtained her master's in social work from Humboldt State and her Bachelor of Arts in Native American Studies. Stephanie was recently appointed to the National Indian Child Welfare Association, or NCTCC, Board of Directors. Stephanie's goal is to provide culturally grounded prevention and intervention services to promote healing and wellness in the Yurok community. Additionally, Stephanie works to advocate for tribal families and for tribal sovereignty. And last but not least, our third presenter, Alita Redner, is a Yurok tribal member and is currently the Indian Child Welfare Manager for the Yurok Tribe. She and her family reside in the village of Wheatspuce at the confluence of the Klamath and Trinity Rivers on the Upper Yurok Reservation. Alita received her master's in social work from Humboldt State University in May 2020. Ms. Redner acknowledges her experiences and engagements as a service provider and has done direct work within her community in multiple capacities, including as a natural helper, TANF caseworker, and Indian child welfare social worker. Today's program and the National Quality Improvement Center for Collaborative Community Court Teams is an initiative of the Children's Bureau in the Administration on Children, Youth, and Families. It was really their creation back in 2017 to develop the National Quality Improvement Center to address infants with prenatal substance exposure and implementation of the Child Abuse Prevention Treatment Act as it relates to infants with prenatal substance exposure. A little bit about the Quality Improvement Center. On the next slide, you can see our partners who comprise the Quality Improvement Center. And it's our honor to have the Tribal Law and Policy Institute as one of our partners. It's been my pleasure to work with Suzanne Garcia over the last 3 years. The goals of the Quality Improvement Center today, we're just going to really talk a little bit about the first 2 goals with implementation and capacity that really address infants and their affected families and caregivers who are affected by prenatal substance exposure, and the implementation of the Child Abuse Prevention Treatment Act that was amended in 2016. And we'll talk a little bit about the legislation in a few minutes, and this will be this part of the CAPTA will be our focus for today's call, and the work that the 2 tribes in Northern California, our tribal sites, two family wellness courts in Northern California have implemented. In today's presentation, we'll focus with Stephanie and Alita on the Yurok Tribe's work in Humboldt County. The quick demonstration sites, there are 14 demonstration sites under the Community Collaborative Courts. And you can see the distribution of the sites. And as I mentioned a few minutes ago, the Northern California Tribal Court Coalition is the applicant agency with 2 implementation sites in Humboldt County and Del Norte County. One of the exciting things about the work of the 14 demonstration sites under the QIC National Quality Improvement Center is the work that the sites have been doing around addressing infants with prenatal substance exposure. And you can see on this slide some of the progress that these sites have made in implementing plans of safe care and addressing infants with prenatal substance exposure. What's been exciting about this work is that these courts have not just focused on families that come to the attention of the court or to the attention of child welfare, but have moved upstream, if you will, into community-based services, into a preventive focus to provide services and supports, including prenatal plans of safe care for families before they come to the attention of the child welfare system. Those prenatal plans of safe care have also served to inform child welfare decision-making at the time a notification is made to child welfare regarding an infant being born with prenatal substance exposure and we believe is beginning to have an influence on mitigating child removals as a result of this more preventive approach to prenatal, to plans of safe care. Brief overview of the CAPTA legislation. Child Abuse Prevention and Treatment Act, 1974 was the original legislation that created the CAPTA block grant. In 2003, plans of safe care were added to the legislation for infants identified as affected by prenatal substance exposure, and at that time, illegal substances. In 2010, infants affected by identified with fetal alcohol spectrum disorder were added to the legislation, that those infants and those families required a notification to child welfare and the development of plans of safe care. And in 2016, the CAPTA was amended by the Comprehensive Addiction and Recovery Act. And you'll see on the next slide the primary changes to CAPTA at that time. Essentially removed the word illegal from the definition of an infant born with and identified as affected substance abuse. It requires specific data to be reported by states, and it required a plan of safe care to include the needs of both families and both the infant and families or caregivers to address both the substance use disorder treatment needs as well as the infant's needs, the healthcare needs of the infant and mom as well. So really, when we talk about what is, plan of safe care, what do we mean by a plan of safe care? The guidance and the statute and from the Children's Bureau, as I just mentioned, relates to the plan of safe care having to address the health needs of the infant as well as the family member, the parent and caregiver, as well as the substance use disorder treatment needs. Plan of safe care is different than a child welfare safety plan. It's different than a substance use disorder treatment plan, and it's different than a hospital discharge plan. Although all three of those plans, can we move to the next slide, please? All three of those plans can inform a plan of safe care. Ideally, the plan of safe care ties together the focus of each of those plans into a coordinated plan, if you will, that the family gets to implement, if you will, and gets to manage in providing the types of services and supports that families require and need who are affected by prenatal substance exposure, if you will. Domains that might be in a plan of safe care are these primary domains. States have some flexibility in defining what goes into a plan of safe care, and this is guidance that we've developed at Children and Family Futures to assist states and tribes and jurisdictions around the domains that a plan of safe care should address. It's important to recognize in the tribal application, the development of plans of safe care in the context of Indigenous worldview. I'd like to turn it over to Stephanie to reflect on that for a moment.
Thank you. I think what's really important is that we don't use a boilerplate and template like we tend to do in child welfare practice. And so ensuring at the core of identity is our existence of who we are as Indigenous people, and ensuring that we are really weaving that in, whether you're a tribal provider or a non-tribal provider, is creating that opportunity to acknowledge their existence and who they are and their identity, and also remembering that everything is connected and balanced. And I think other important key aspects is that we recognize that not every tribal and Indigenous family is the same. They all have a different experience as far as their connection to their identity of their tribal family, their tribe, and who they are as a result of genocide and historical trauma. But if we don't ensure those key components, we're then again just creating another form of really genocide if we're not connecting our Indigenous families to the context of who they are and recognizing what kind of trauma has impacted their family and the cultural and tribal connection and identity. Thank you.
Thanks, Stephanie. So it's important that the plan of safe care address both the cultural as well as the spiritual, physical, and mental needs of the entire family, as well as the infant, but be holistic in that approach. And with that, I'd like to turn it over to Suzanne Garcia with the Tribal Law and Policy Institute.
Thanks, Ken. Hi, everybody. I would like to acknowledge that I'm speaking to you today from the homeland of the Washoe Tribe of Nevada and California. They've lived here since time immemorial, and all of the land around the lake was taken from them. But they're resilient. They have gotten some land, a little bit of land left back here up at the lake. And also they operate Meeks Resort and Lodge on the west side. It's a really pretty part of the lake. So if you come up to Lake Tahoe, I encourage you to go and visit them there. So I'm going to talk about three basic things today. So first, I'm going to set some context using some current data. As an ICWA practitioner, I really hated these cases. You know, it was another child born affected by substance use, and another child separated from her immediate family, you know, from her mother, and also from her extended family, while the state and county system kind of worked its way through its process. And as you're going to see from the data I'm going to show in a little bit, you know, that method wasn't working. The problem is continuing to get worse. So that's going to be my first thing. My second thing, I'm going to talk about best practices for the plans of safe care and kind of bring them together with some of the language from the 2016 final rule on the Indian Child Welfare Act, because I'm hoping that they will provide us a structure for possibly a new model. And as a bonus, by bringing the two together, we increase compliance with state and federal laws. And finally, I'm going to introduce the Northern California Tribal Court Coalition's 2 demonstration sites that Ken was talking about as a transition to Alita and Stephanie's kind of presentation. So, okay, the data. So we recognize that this data is flawed for a number of reasons, but one is that Native families are often misidentified. But as you can see from this slide, the trend is going up. The number of children removed because of substance use is continuing to rise. And on the next slide, thanks, Naomi, you'll see that a large number of these children are less than a year old. So the numbers are kind of moving up on a similar trajectory, but the upshot, I think, is that over 50% of the 1 and unders are being removed because of substance use. And when you look at the Native population, these Native families, the number goes up. The number of 1 and unders is removed because of substance use is approaching 70%. Neonatal abstinence syndrome, this was a study done in 2016, is higher than with other populations. And I don't think this is information that is surprising to those of us who work in this area. It's just putting numbers onto things that we already kind of know. Now, this is a slide that reflects something that I didn't know. This slide reflects information from one state, and we don't have this information broken out specific to Native families. But so the period, there's a term called the 4th trimester, and it has a couple of different definitions, but for our purposes today, what we're talking about is the year after the baby is born, is considered the 4th trimester. And women who struggle with substance use are passing away. We're losing them during this 4th trimester, especially between the 40, you know, about the 40th day and the end of the first year. Substance use related deaths are skyrocketing, and they're becoming one of the main reasons that these mothers are dying. It's right up there with heart disease and some other more common, you know, reasons that we think for mortality. I didn't know this when I started this project, and I was really kind of shocked by this number. So what do we do? Obviously, we got to find a better way to engage families and to serve them. But I think we have an opportunity here. You know, the answer might be right underneath our nose. So let's go back to those plans of safe care. You know, Ken kind of went down through the different times that CAPTA was amended, and the plans of safe care, you know, they've gone through some different changes, but one thing that hasn't changed is that really only general guidance is given. The states are largely in charge of deciding what specific form and content goes into those kind of the template plans of safe care. They have a lot of discretion in bringing people to the table and deciding, you know, roles and responsibility, who's going to be driving these plans of safe care. But one thing we have seen is that when stakeholders were brought together to decide what should be in these plans of safe care, the tribes are often not included. They're not part of those discussions. And I really think that was a missed opportunity for a number of reasons. So these plans of safe care, these are some, you know, Ken talked about the work that's been done in developing best practices. And here's some of them right here. So ideally, you know, they're developed prior to the birth of the baby, of the infant. And that just makes sense, right? You want to mitigate the effects on the child. You want to get in there with the mom so that there's not an emergency situation when the baby is born. There's some kind of a plan in place and also to help prevent the separations. You know, it's best if they're driven by a kind of a comprehensive multidisciplinary assessment. You want to engage with the family at multiple intervention points. You know, you want to really get out there and work with them. Like Ken said, they're supposed to address the needs of both the infant and the family, the caregiver, and really the entire family and possibly the community as well. And the idea of those is to have a structure in place to ensure coordination and engagement with services. Now, as I was learning more and more about these best practices, as an ICWA practitioner, this is where my head went. This is language that I took from the BIA's quick reference guide on active efforts. And I really saw the similarity between what active efforts requires and the best practices for these plans of safe care. So, you know, so here's the two side by side, right? So active efforts are supposed to be affirmative, they're supposed to be active, they're supposed to be thorough, they're supposed to be timely, right? Timely, you know, ideally developed prior to the birth of the infant, right? They're supposed to be thorough. You know, the plans of safe care best practice, they're driven by a multidisciplinary assessment. They're supposed to be active and affirmative, and the multiple points of intervention, I think, meshes nicely with that. It's a structure in place to ensure coordination and access to engagement and services, right? Well, active efforts are supposed to be documented and put on the case record. So if the judge is asking for these plans of safe care within the hearings, that's an easier form of documentation. It just kind of flows. So I don't want to say that if a child has a plan of safe care that they automatically, this means that active efforts have been made. There's a lot more to it than that. There's also the requirement that these active efforts be provided in a manner consistent with the prevailing social and cultural conditions and way of life of the tribe. They're supposed to be done in partnership with the tribe and in partnership with the family. And that's where I think, going back to the state's kind of discretion to develop these template plans of safe care, having the tribes at the table to decide what those template plans of safe care might look like, and then in practice, on case to case, working with the tribes to develop with the family these plans of safe care and implement them. I just think not only is this an opportunity to, increase compliance with both laws, I'm thinking that this is a better way to engage families and hopefully bring those numbers that we saw at those beginning slides, bring those numbers down. So,
Suzanne, can I add?
Yes, please.
So I just want to really emphasize that it's an opportunity to build together those plans and work early on to do the true intention of ICWA. And I saw a question come through about what ICWA is. So I recognize that there's probably medical and other providers that don't work necessarily under child welfare, may not know. ICWA is the Indian Child Welfare Act, and it's a federal law that was enacted in 1978 specifically for state agencies to follow when removing or working, not just removing, but when child welfare proceedings are initiated with an Indian child. And so it's a very, I think it's been around a while, 43 years, if I do my math correctly. It's really guidance for the states on how they're to work with tribes when working with an Indian child to ensure that child is connected and not removed as a result of our country's past history of removal to assimilate and destroy Indian people. So it's a very important law. And what's important is that active efforts, as Suzanne said, this is not how you check the box off by saying I've met active efforts. It's one way in which the intention of ICWA was to do preventative efforts prior to any court involvement to prevent the breakup of the Indian family.
Thanks, Stephanie. And I apologize. This is, I'm used to presenting in a room with people to where I can, catch where people's questions are. And I didn't see them at the bottom of the thing. So I really appreciate you jumping in there and explaining what the Indian Child Welfare Act is. So next, I am going to move forward because we're going to transition to what Stephanie and Alita are going to be talking about, which is the plan of safe care they developed in their process. So the QIC, when the funding announcement came out, tribes were allowed to designate someone to apply for them. And what the Yurok Tribe is, they designated the Northern California Tribal Court Coalition to apply for the grant in their stead. And they were successful. They were awarded 2 demonstration sites. One involved Yurok, Hoopa, and Humboldt County. And the second site was Yurok and Del Norte County. And on this slide here, we have their vision and their goals. And I think initially when they were first awarded the grant, they were going to be focusing on developing their joint jurisdiction family wellness courts. And it's a great model where the tribal court judge and the state court judge sit on the bench at the same time. Tribal law is implemented. State law is implemented. All of the resources can be marshaled to best assist the family. And I think the plan of safe care, they were going to go with the state and counties system for those plans of safe care, and they were going to use them. They were going to be more concerned with using them with families that were appearing in front of the court. But as they got into the project, the focus kind of shifted. And so now I'm going to transition this over to Stephanie and Alita, and they're going to talk about their work on this project.
Great. So Suzanne shared a little bit of the history. I'll just say initially when I started, I did work for the county in child welfare, specifically when this grant was first obtained. I was not working for the tribe yet at that time. And I think all of us as partners were really vested in the court process because that's what we had committed to until we went to one of the grantee meetings and learned that there was this whole plan of safe care that we were responsible for. And as a previous child welfare director, we hadn't even looked or talked about these plans of safe care, even though it had been, changed in law for quite some time. So I just want to acknowledge that systems are overburdened. And at that time, we thought we were really focused on the grant, but through a lot of the work and evolution of shifting and times changing, what really needed to happen was really whose responsibility, what would it look like? And again, we were focused on Next slide, please. We were focused on building of this joint jurisdictional court. But as the director of the Yurok Tribe, we really had to focus on looking at our partnerships and looking at our families. What we knew at the time is that things weren't changing, and we were seeing the outcomes were not changing. We were seeing more babies be born opioid exposed and other substances, and we could see those impacts, and we saw the increases, and we continue to see the struggles of our families. And we saw both of our partners in both Humboldt and Del Norte County struggle with, well, we jurisdictionally, child welfare is stating, we jurisdictionally have no role when a mother is pregnant. That's not our lane, not it. And for many, for that reason is a good reason. And we would say, well, that's the state's responsibility. We don't have the resources or structure in all of our brainstorming. And mind you, at the same time, we were developing our partnerships as a result of this joint jurisdictional court, and we could have some of these conversations or unspoken thoughts at times. And at one point, we just had to say as the tribe, you know what, these are our children and our families. As much as ICWA is the responsibility of the state, at the end of the day, when child welfare is gone and out of the picture, these are still our children, still our parents, whether they've reunified or not. This is our community. These are our children. And if we want to see something change, we need to hop in there and figure this out, because we are across 2 or 3 counties and we might as well give it a try. Yes, we lack staff, far more than state systems and county systems. We lack the infrastructure and the financial resources, but what can we leverage to make something different? Because everything we tell the counties is true. We know our families better. We know how to connect. We know what they're struggling with. They're our neighbors, they're our family members, they're us. And so what is our role and how can we make this happen? And what does this look like? Because we can't sit around to say like, this isn't working, this isn't working. What's the shift? And so we had to do some internal shifting and thinking, which was really hard because as a government and with failing, not having enough financial economic resources and being overloaded ourselves, it's a hard shift, but culturally it's the right thing to do as tribal people, knowing that our families are struggling and really having that hard discussion with our partners about, even if ICWA were to be followed 100%, what would it look like? What would stop the gates and the doors from opening for our families to go through child welfare? What would that look like to not have our families at the attention of child welfare? And this is just one of those ways in which we believe that can happen. And so I really want to acknowledge 2 of our staff that weren't able to join us today for really doing the hard work of developing this. By far, we have a lot more to do, and we've started very small through these partnerships, but I'll go ahead and go into the next slide, and we'll start talking about what that actually looks like. For us, just to give a little context, we're way up north, the 2 most northern counties in California, and we are the largest tribe, but we are mostly grant funded. We're fairly young as a government in that we were federally recognized in 1993. We also are working on a tribe-state Title 4E agreement. We have Title 4B. We have a high number of our children involved with the state system. We have a very active and well-developed tribal court. I think the other things to recognize geographically, we're very spread, very thin. We have a huge geographic region like many tribes. And so we have very few staff because we get very little funding from the BIA. I think the other important piece is working across very different counties and county lines and jurisdictions. However, our families don't see those lines and regardless still have the needs. And there's a lack of, the reason why I share this is for like many tribal areas, there's a lack of access or resource to services. So we have to get very, very creative in figuring out how do we work with our families very early on. Next slide, please. And so I just want to remind for many of you, it might be the first time you're hearing about ICWA or the first time you've heard about genocide. Just being from this country, it's really important to recognize some of the harsh impacts that our people, the genocide, have experienced. And in particular in our area, that really specifically in California, there's a huge documented practice around slavery, bounties, and the extinguishing of our people. It's very much documented, and I think it's important to know your history of the people that you're serving, particularly This gentleman here, I don't like to say his name, is one very much responsible in our area for exterminating and killing of our people. Go ahead. And then go back one more. Just important also to know that the Indian Adoption Project is another one of those historical moments in which this country moved our children from their identity and their family to assimilate them and to wipe out who we are as Indian people. And I think a good question to ask you, no matter, ask yourself and your agency is, what is your practice really as your agency, and how are you serving Indigenous people? And how is your practice different than what was done during the Indian Adoption Project time periods? So it's just something to think about when we talk about shifts in systemic racism and oppression. How are you serving the people, this nation's first people? Next slide, please. And then, so again, thinking about our cultural values, we had to really think about those things and to share with you how important why we came to the point of, you know what, we need to be the ones to do these plans of safe care. There are people, we'll figure it out, is that there's a really important aspect around connection. We hear a lot about bonding, but I hear over and over again connection, and that's what's important. For us, connection and connection to environment, to caretakers, to spiritually, connection is really critically important in our culture. The first 10 days are so very important of a baby's life, an infant's life. Many tribes have different beliefs around that, but for us, the first 10 days, the baby is a spirit, and that spirit is deciding whether to stay here or not during those first 10 days. And so this picture here is one of my daughters in one of our baskets, and we raise our babies in baskets. There's so much importance to our baby basket in traditional child rearing practices around connection to the world, connection to the person holding you, connection to ancestors, all of those things. This basket protects this baby and creates a safe environment for connection to those things. I think other important cultural values to recognize that are very different than the general population is that a lot of our culture is based around accountability and responsibility, balance. And I always like to use shame as an important piece of language. Shame is about accountability and responsibility. Oftentimes social work practice will say things like, no shame, no blame. For us, shame is not always a bad thing. Shame is about responsibility. So there's just a lot of cultural values and language that are important to recognize when working with tribal people. And another piece is for traditionally and our values, our children are not owned by their parents. Parents might be the primary caretakers, but children are a community and a village responsibility. Everyone has a responsibility to that child. So it's a very different way of thinking. And then there's roles and responsibilities for everybody in that family to care for that child or that village. And a lot of ceremony is important, as well as our justice system and restorative justice about keeping balance and responsibility. And I share all this in that this is the way we think around when we start looking at responses and interventions and how we're going to work with our families. We try to keep many of these key values in mind. Next slide, please. So I'm going to go ahead and have Alita talk a lot more about our actual plans and what we've done, keeping in mind baby basket, the concept of a baby basket, a village, and a family, and then really talk about the history of the development of the Cares of Safe Plan and what our cares look like and the name of our project.
So we, in learning about the Plan of Safe Care, it was an amazing opportunity to create a path to address opioid use disorder within our community and for our people, and to understand where that intersectionality is between the perinatal stage and the postnatal stage for our women. We're fortunate to work with our language committee to obtain the name called ECANOR, which is to keep safe. And in doing that, we're looking at both the womb and the woman's health. So as a result of attending the stakeholder meetings for the Family Wellness Court, a subgroup was convened, and that was made up of medical providers, First Five staff, tribal staff, and then IHS staff as well. And what we were able to do was to really identify how and when is it appropriate to implement a plan of safe care. But more importantly, it was to how do we interact with each other? How do the tribes and the child welfare system, as well as now we have access to medical staff and their assessment and understanding that, so that we know when it and how to apply that back to our families and for these infants. I want to touch back to the domains too, and understanding how we work within our tribal communities. Oftentimes it's a parallel process, so that we're interpreting these systems, how it impacts our families, but then we're also doing the work as it really relates to stigma reduction. During this time, we had a significant, I think there was five births in a 2-week period where these infants were removed. And we had to look back and say, okay, you know, we have access to medical assisted treatment. How do we let our community know, let our women know that it's okay to engage early so that we're seeing less of an impact at birth? Oftentimes, these moms have already had 4 or 5 children removed, and we felt like at some point we had to repair the interpretation of validating their identity still. And that too went back to the domains of assessment.
I think what's really important to highlight here is Alita always doesn't always talk herself up, and she's very humble. But I have to say, in the beginning, as her supervisor, I gave her the charge of really saying, you know what, pull all these providers together. We've met, they're ready to go. There's a sense of urgency. Come out with your plans, map everything out, just as an administrator can do at times, when really it did not take that shape. And maybe you can speak to, like, it was really about learning each other's systems and building that relationship with our partners.
So yeah, I mean, to speak to the partnership and the collaboration, I think we have to understand that the impact of knowing each other's systems is really, that took a lot of time. Like, that was a year in itself, just to say, I am here, this is what we're doing, this is when we interact with the mother. And then, okay, well, the tribe interacts, you know, postnatal, prenatal, how do we best reach these moms? And the stigma reduction portion of it is just to say we have a path. We recognize you, we recognize opioid use disorder. Like, we want to engage early on, and we also want to provide the best assessment. I want to give credit too to some of the screening and the assessment portion, and understanding. I think that's what we learned most, is like, what are those methods to keep the child and to ensure that attachment stage, postnatal, and we learned about the eat, sleep, and console methodology and how important that is. And for us, that really tied back into our cultural significance of the first 10 days of life, and to continue to create, like, the opportunity for the mom to stay in the hospital, to have that bonding time. But most importantly, it's to have the culturally significant assessment portion, that we are creating this path that allows us to continue to work with these mothers and to validate our identity and to validate the resilience of the child.
To really create that opportunity for the moms and the family to know that we're there to help them. And I think that's our next big push, is to really work to ensure that our community knows, just as culturally and traditionally as Indigenous people, that we're there to take care of one another. Sometimes our families can see us as a part of the system because we do get involved when something bad has happened. And so we're really trying to shift that and to validate, like, you might be stuck and there's a way out. There's a way out. And that's why the baby basket is so significant and so important. I'd just like to point to this picture up here. This picture was back in 1977, right before the Indian Child Welfare Act was passed. And these were all young mothers. The lady on the left is my mother. She was 16 and I'm right there. And really, that basket was a huge part of my upbringing. But many of these infants here, they're all young mothers, but they were a support network for each other, as well as the larger community and family. And so we're really trying to replicate and keep that in mind. Assessments are important. All of these evidence-based pieces, yes, those are important, but really that cultural connection and identity and validation of, you know, your family didn't get this way overnight. You didn't end up in this spot overnight, and we're here to help you figure it out, and there's options for help. Next slide, please.
Yeah, we can't be dependent on the funding, like we can't be dependent. We have to create the path.
So some of the ways we did that, I'm just going to talk a little bit because we do have to talk about funding and infrastructure, because you do need staff, but a lot of our staff are from the community. And so again, they're doing the hard work. I had the job or responsibility of figuring out how we're going to fund our staff or be able to fund with what programs we have. And so really thinking about leveraging and you know, kind of braiding funding or looking at what the opportunities are. We do have a tribal TANF program. So a lot of this work fits well under Purpose Area 3 and 4 under tribal TANF specifically, and then leveraging our BIA self-governance dollars and the grants that we have to try to figure out who can we reassign and who's best fitted to work with our families. Initially, the first families that we implemented these plans were already involved with the child welfare. And so it was our ICWA staff that did these first few plans, but we're working now to identify have our TANF staff do their earlier prevention. So if we have a family that is not involved with child welfare, we really want our TANF family advocates to be working with these families, even if they don't have an open cash aid case, that they're building that support through our TANF program. And then looking at what other benefits are around to help support and leveraging all of that support to develop the plans and to work collaboratively to help them be able to have that harm reduction and stay engaged. And yes, we know it's challenging when somebody gives birth and they're addicted. There's the nodding off. They might want to run off rather than visit. But with this team around them, some of that can be minimized and decreased, and getting them on mat and having a little less impact at birth. And it doesn't necessarily always mean child welfare will not get involved, but it might be a less, maybe potentially not separating or out of home care. Or if there has to be out of home care, how do we get mom into treatment quicker and baby there to visit or baby down in treatment? So those are the opportunities to leverage and to be able to have these plans ahead of time. And then of course, just really making sure we have folks connected to cultural healing. Alita, do you want to talk a little bit more about how the plan looks in practice?
Yeah, if we can go on to the next slide. So this is our flow chart. Really, we identified as a part of the domains we had talked about in the assessment portion is how do we incorporate the self or if family referral, like that's the stigma reduction within the community. We look at our tribal systems, our medical systems, and then the county, state child welfare systems, and where and when do those intersect with the mother and the infant. This plan is specific to the substance use disorder for pregnant women. We're fortunate to do intakes on multiple levels. Again, not being specific to a system or a program, but to be open to our entire department to be ready and able to embrace the intake process. We continue to do the referrals for other tribal resources and advocates, both at clinical for navigation, and then within our internal process to be a holder of the plan of safe care, meaning to work with the mother. Once the plan is initiated, we have used that to collaborate with the county system and the state system during child welfare emergency responses, and using that plan to guide the decision-making for safety and risk factors as it relates to the family and to the child. And then to continue to just incorporate building that healthy community and the healthy environment and the family system. And oftentimes we have to replicate that family system in order to support the mother through this process.
Great. I see a lot of questions coming in. Do you want to go to the next slide? I know we covered a lot, and I see a lot of questions directing at some of us. So I'll pass it over to Ken, because there was a lot we covered there in a short amount of time. So thank you, everyone, for allowing us to share our work at Yurok. Just know that we're just beginning. This is just a start for us. We hope to have it much more advanced to really impact and help our community in a different way. We're just trying things on, and that's my words of encouragement to all of you is try it on. If your outcomes aren't working, try something, just try it on and see how it goes.
Thank you, Stephanie and Alita. We have some questions. We have a little bit of time. I apologize for being pressed a little bit here. Can you talk a little bit about the different disciplines that are involved in your multidisciplinary work, and I know you've expanded. One of the things, many of the courts have expanded their partnerships, and you're doing this outside the court, even though you partner with the court, but you're addressing families that are outside of the court as well. Can you talk a little bit about those other team members, if you will, or other partner systems that you've had to engage?
Yeah, for us, we're very fortunate to have providers from First Five who did some of that navigation work. We've got nursing individuals from the local hospitals. We've got medical providers from other clinics, such as Open Door Clinic and United Indian Health Services and IHS Clinic. And then we have our internal staff, which would include child welfare social workers, as well as TANF case managers, and they're also called family advocates. So those are specific to our TANF program.
Thank you. Thank you.
So I think some of that had to do with the readiness of our community. There had been a lot of pre-work done. I think not only through this grant, but Humboldt had received the court there had started the first joint court prior to this project. And I think a lot of work there, also acknowledging the child welfare system, and Humboldt County was working to do a lot of system changes. And then of course the Attorney General was involved in Humboldt County. So I think the community Humboldt County did a lot of work with community partners to really look at shifts and changes. And I think the hospitals just seeing the patterns over time, as well as our community as a whole wanting to see something different from the impacts of opioid use. I think creating that sense of urgency as well as the readiness, they were on board the moment that the grant, or the planning for the first grant, and then the grant was received, a lot of the prevention partners, but they weren't quite sure what their role was and when to start. But keeping them connected and allowing them to pause when it was time for them to pull them back in. We didn't ever know when that was going to be, because of course we all wanted to get to prevention or earlier intervention. And it happened by chance that everyone was ready. And there was a lot of relationship work being done. And I think if you're a practitioner and you see that there's struggles with your agency or your partners, it's an opportunity to really do some internal work with your leadership and administrators to sit down and have relationship meetings and regular meetings with your partners or your tribes to develop commitments or agreements. I think that's the part what was so ready, is that the Yurok Tribe and Humboldt County DHHS and Child Welfare had been working for some time with many highs and lows to develop the relationship and to start making it more formalized after many, many years. So I think that's a really prime opportunity. And I could say for our families, some of them were fearful, some still are, to go to one of our 2 hospitals. I've heard from some clients that don't have your baby there. They don't know Indian people. They're really harsh. They drug test everybody. So those are the kinds of things we can talk about and start working through our relationship. I also, it may not decrease the number of referrals because there's the responsibility for the medical provider still have to make that mandated report. But what it does is that if we're working with that family together ahead of time, the panic and the frenzy and the fear of when that investigation, if it occurs, happens, that there's a plan, and the impact to the infant is much different. So say we get the mom in earlier and she's able to get on to MAT, medicated assisted treatment, and we have this plan with all of the players. That plan should ideally go at birth and the hospital would know about it. They still have to make their mandated report to child welfare, but the team comes together and it's a different conversation rather than nobody knows this mom and nobody knew she was pregnant. She gives birth and everyone's like, oh, we've got to find an emergency placement. We know, there's been no prenatal care, all of that. So it could look very, very different. I know I answered a bunch of questions in one. Sorry about that.
Yeah, that's such an important point because it looks so different. Instead of a crisis response, to have a family engaged, a woman engaged prenatally prior to the birth event, prior to a notification or a mandated report that can inform a child welfare response. There's nothing in the legislation, even though the legislation is vetted in child welfare, and child welfare is responsible for receiving the notification or the report. And the legislation specifically says the notification is not to be create a separate definition of abuse and neglect. But there's nothing in the legislation that says who should do a plan of safe care. And what the work that you've done in Humboldt County in the Yurok Tribe has taken that on outside of child welfare in order to support families in a preventive way. It also aligns with Associate Commissioner Jerry Milner's vision for preventing child maltreatment and preventing removals, in that the work that you're doing, and again, prenatal plans of safe care for families outside of child welfare can, as you said, can mitigate either removal or could enhance reunification in those situations where removal does occur. So thank you for that.
Ken, I want to speak to one more thing. I know we're getting close on time here. Somebody just brought up something really important. I think most tribes and many of us struggle, and partners are asking this, what to do when all of maybe the immediate family are substance abuse affected or struggling with substance abuse, and what do you do then? And I think it's not an easy answer, but I know that we as tribes struggle with that. And I think what's most important is bringing the family there and still ensuring that visitation and pulling them in early on, and then working with the tribe, ensuring that you're working with the tribe to identify maybe other people in the community that are tribal or very extended family, because as Indian people, we all know who our relatives are, even if we're disconnected. We can go back generations and generations or all the way to the 50th cousin. And I think that's why it's so important to work with the tribe, because bringing in people oftentimes who are isolated or disconnected because of substance use is so important. And so it's not an easy task, but that's why that much earlier work is so important, is to reground and bring back family and create those opportunities. And I think working with other partners to offer those family members treatment and healing, because we are talking generations of historical trauma. So you will likely seeing 2 and 3 generations of family members who are impacted by substance use.
Thanks, Stephanie. So the next slide, we're wrapping up, but the next slide has some of the resources specific to tribal child welfare and cultural context for this work, as well as information, as you can see, active efforts and ICWA. We're not going to go through the resources page. There are lots of resources, slides, if you will, and that has lots of information around much of what we've been talking about today. If we can move to the contact slide, this webinar will be provided to you, to all the registrants, even those who aren't able to join us today. So we'll get this out probably within the next week, and as we scroll through the resources. So here's how you can reach us. You see all of our contact information there. Suzanne and I are part of the quick collaborative community court team, TA team, if you will. Stephanie and Alita are working in Humboldt County as a member of the Yurok Tribe, with the Yurok Tribe, to address infants with prenatal substance exposure and families. And so you feel free to reach out to any of us for additional information. If you'd like to request technical assistance, you can do that through the quick team web address, if you will. We appreciate your time today. We know how busy everybody is. We know this is a stressful time on many levels, and we again thank you for being with us. We wish you well in health and rest, and caring for each other, and caring for our communities, and caring for our families during this time. Stephanie and Alita and Suzanne, thank you very much for all you're doing and for making yourselves available to share your work and your passion with all of our participants today. Be well, everybody. Thank you.